Hey, good morning. I am Kalyan Bonda. Today I am going to discuss an interesting case of cerebral area embolism. So the keywords that I am going to use repeatedly in this case are CAE, which is cerebral area embolism, CVC, central vein catheter, and CPSE, complex partial status epilepticus. So coming into the clinical picture, a 72-year-old male with medical history of coronary artery disease and mechanical aortic wall and warfarin presented with worsening chest pain and shortness of breath. On admission, the patient had mild temperature elevation and elevated cardiac enzymes. A right internal jugular venous catheter was inserted due to poor peripheral venous access. A trans-esophageal echocardiography was done due to the suspicion of infective endocarditis and a mechanical aortic wall. So the TE findings are right to left cardiac shunt through patent foramen ovale. However, no vegetations were found. So the patient was diagnosed with non-ST elevation myocardial infarction, for which he undergone triple vessel coronary angioplasty, and after the procedure, he was started on antithrombotic therapy. The patient was deemed stable for discharge. The CVC removal was done in upright position, and after 15 minutes, an acute worsening of neurological status was noted with difficulty in speaking, gaze deviation to the right, left-sided weakness, and left-sided sensory loss. A stroke code was immediately activated with initial NIH stroke scale of 14. An immediate non-contrast CT head was done, which showed no hemorrhage or hypodensity, but air emboli was noted in bilateral hemispheres. On clinical examination, the patient showed a fluctuating mental status with left hand shaking. So here we can see the hypodense or dark colored sulcal hair, which is present in the precentral sulci and central sulci of the right frontal cortex and in the intraparietal sulci of the right cerebral hemisphere. So as the patient showed clinical signs of a seizure, he was treated with intravenous lorazepam and loading dose of levetiracetam. He was also initiated on high flow oxygen, and then he was transferred to neurosciences ICU. A continuous video EEG monitoring was done, which revealed features of complex partial status epilepticus. So here in the F4 and the C4 leads, F indicating the frontal and C indicating the central, and the 4 the even number, which shows that the epileptic general focus is present on the right cortical hemisphere. So for the seizure control, the patient was intubated for better airway, and multiple antiepileptics like phosphonatoin or jonasamide were tried without any success, but the general anesthesia midazolam was introduced with successful control of the seizures. The patient was deemed seizure-free for 24 hours and the EEG monitoring was stopped. The brain MRI had shown multiple confluent gyriform restricted diffusion lesions in the right cortical hemisphere. The patient had a gradual clinical improvement and he was discharged to rehabilitative facility with left-sided hemiparesis. Here we can see the diffusion-weighted imaging of the patient head, which showed hyperintense or bright lesions of gyriform restrictions, which meant there is restriction of the water molecules here. So coming into the discussion, these are the table of contents that we are going to discuss. So the definition: air or gas embolism is a medical condition that occurs when air or gas bubbles enter the bloodstream and travel within the circulatory system. Epidemiology: the true incidence of vascular air embolism remains uncertain due to its non-specific symptoms and challenging diagnosis. Estimated occurrence during central line placement is like 0.2% to 1% of patients, and interventional radiology reports a 0.13% incidence during central venous catheter insertion and removal. CAE can be deadly even with small cerebral air volumes as small as 2 ml. So coming into the etiology, air embolism can result from almost all clinical specialties. Therefore, it is important to be aware of this condition. So here we can see uh, medical specialties which reported no cases of gas embolism. And here we can see this patient's mechanism of gas embolism, which is entry of air through disconnected intravascular catheter. So we are going to discuss the risk factors for cerebral area embolism during CVC removal. Being the patient in upright positioning and being in the deep inspiration phase, or even in the hypovolemia, the patient can have an increased risk of having a cerebral area embolism, because these three risk factors have one thing in common, which is reduced cerebral central venous pressure. As the central venous pressure is very low, when the CVC was removed, the outer atmospheric pressure overcomes the central venous pressure, allowing the air enter into the venous circulation. So pathophysiology. Two proposed mechanisms were shown on how an air embolism can enter into the cerebral vasculature bypassing the pulmonary system. So these are retrograde flow, right to left paradoxical passage. So the first one, the air bubbles which ascend against the venous blood flow entering the cerebral venous system instead of the pulmonary circulation. Here, which results to the cerebral venous air embolism. Greater the bubble size, greater the buoyancy. So factors that potentiate this mechanism are lack of jugular valves, pulmonary hypertension, severe tricuspid regurgitation, and venous stasis. The other mechanism, which is paradoxical passage, shows the venous air enters into the arterial system through cardiac or pulmonary shunts like this, bypassing the pulmonary circulation and entering into the brain. This results into cerebral arterial air embolism. As in this patient that we are discussing, the bypass of the air bubble occurred through the patent foramen oval, which is found on the TE. So how a cerebral air embolism can cause a neurological injury? So three mechanisms were proposed through which CAE can predispose to neurological injury, which one is mechanical obstruction of the distal cerebral vasculature, second is the endothelial irritation, and third is the immune response activation. So the first one is the air bubbles mechanically obstruct the distal cerebral arteries, which impair the blood flow, causing neuronal injury and the cytotoxic edema. This mechanism is similar to that of the ischemic stroke. And this is the endothelial irritation, where the surface of the air bubble irritates the endothelial cells, which eventually leads to the blood-brain barrier disruption. The third mechanism is the surface of the air bubble activates the immune response, which leads to inflammation and further brain injury. So the post-stroke epilepsy and status epilepticus, the before mentioned three mechanisms lead to reduced glucose and oxygen transport to the small cerebral arterioles, which can be as small as 30 to 60 micrometers, which leads to variations in the cerebral perfusion and cortical neuron. This leads to the variations in the cerebral perfusion and also the mechanisms causing the cortical neuronal injury, which eventually leads to the epilepticogenic alterations which cause post-stroke epilepsy or status epilepticus. As we can see, the patient had experienced complex partial status epilepticus, which is a prolongation of complex partial seizures, which is also known as focal impaired awareness seizures, which start from one epileptogenic focus and you know spread to the other parts of the brain. So let's go to, yeah. So the factors for unfavorable outcomes are old age, encephalopathy, hemiparesis, and gairiform air on the initial brain imaging. So here, Chen et al. Identified distinct imaging patterns in the cerebral area embolism patients, including gairiform, which is here, which runs along the gyrus, and the parenchymal or subarachnoid air bubbles, and the venous sinus air bubbles. So the importance of neuroimaging. Always the neuroimaging remains at the highest priority in differentiating different neurocerebrovascular diseases. So here, in this case of a cerebral air embolism, diagnosis can be established using a non-contrast CT head or a diffusion-weighted MRI sequence. But even though neuroimaging is the paramount importance, there we can face some challenges and dilemma in the diagnosis. So on repeat neuroimaging, there can be a rapid resorption of air emboli through tiny arterioles where we cannot see any air emboli in the cortical hemispheres. And we can also see the gyriform restriction diffusion in the cerebral air embolism, which is caused due to cytotoxic edema or the blood-brain barrier disruption, mimicking the cortical laminar necrosis, which is often seen in various energy-depleted conditions like ischemia, hypoxia, or seizures. So, for this, high clinical suspicion is required because encephalopathy and cortical laminar necrosis can confound the clinical picture of cerebral air embolism. Here we can see an example. This is an DW imaging of a gyriform infection caused by the cerebral air embolism, and this is a diffusion-weighted imaging of a cortical laminar necrosis. See how these two can possess a diagnostic dilemma. So coming the EEG monitoring and its importance. Prolonged EEG monitoring is essential for any patient with the possibility of a seizure because through the prolonged EEG monitoring we can detect the status epilepticus and we can prevent any worse clinical outcomes. So the preventive measures. So the case of the patient which led to the disastrous events is the improper technique of the CVC removal. So to prevent this cerebral air embolism, a correct CVC removal procedure should be practiced, which is the patient should be in the end of the inspiration phase and should be placed in the Trendelenburg position where the legs will be tilted up. So this will increase the central venous pressure, so it can overcome the atmospheric pressure. And while withdrawing the CVC, it should be done in a slow and continuous manner, and a mechanical pressure for with an occlusive dressing should be applied for greater than 5 minutes. So at last, uh, coming to the treatment varies between two types of the gas embolism. It varies for the venous and the arterial, but the supportive therapy and the positioning of the patient stays the same. So for the patient here, the patient of the interest who has been experiencing this arterial gas embolism, the primary therapy would be hyperbaric oxygen therapy as soon as the patient's condition is stable. And the adjunctive therapy can be a lidocaine, which is a anesthetic, or a type 1B anti-arrhythmic agent and anti-epileptic agents, and physical therapy. Anti-epileptic agents are given for any patient who have developed seizures, and physical therapy for any patients with residual focal weakness. Right. Thank you. Thank you, Dr. Bernard and Dr. Spain and Amiquity for giving me this opportunity.